Good afternoon. I'm Sandra Arevalo from Montefiore Nyack. I'm the Director of Community Health and Wellness. And today we're having another community chat. This time we're going to be talking about home care or home health care, because really what we are bringing is health care to your home for either yourself or family members or loved ones who need of that special caring care, unintended, at home. So today we have two experts with us. One of them, Colleen Nunez, welcome so much.
Thank you.
And she is the director of home care at Montefiore Mayan Hospital. And Menachem Colt, who, of course, it's going to be introducing also his agency, Home Community Care, right? Menachem, did I say it right?
Community home care.
See, I okay. So maybe Colleen, do you want to start and do you want to tell us a little bit about you and your role?
Sure. So I'll share my screen. I think I can share my screen.
Yes. And while Colleen shares her screen, I would like to invite all of our attendees to participate. Please use the chat, the Q&A, send us comments, questions. And as we move along, I'm going to be reading these comments and questions to our experts. So please, I want you to know this space is really thought with you in mind. So take advantage, please. And we can see the screen. We can see your presentation.
Great. Wonderful. So good afternoon. My name is Colleen Nunes, and I am the administrator of Montefiore Nyack Hospital Home Care. Montefiore Nyack Hospital Home Care is a certified home health agency. We are regulated by the Centers for Medicare and Medicaid Services, and we are accredited by the Joint Commission and the New York State Department of Health. A certified home health agency means we provide services that are intermittent, skilled, and short-term, all directed by a physician's order. We have an interdisciplinary team to ensure the best plan for the patient's safe transition home. Our goal is to provide the best nursing care and rehab services to allow the patient to achieve their highest level of independence and remain in the comfort of their home. Someone who would benefit from Montefiore Nyack's home care services would be the patient who has been recently hospitalized and has been weakened from the experience and needs skilled care. Skilled care are services that can only be provided by a licensed professional, such as a nurse, a physical therapist, or an occupational therapist. Examples of skilled care might be wound care, catheter care, gait training, or education in the use of an adaptive equipment. For example, someone who is hospitalized for a heart attack or has undergone cardiac bypass surgery, upon discharge home, this patient would require skilled nursing to monitor their heart, ensure their surgical wound is healing, educate them on their medications and signs and symptoms of heart disease. And this patient might require physical therapy to help rebuild their patient's strength and endurance. Another example that's appropriate for home care might be the elderly patient who fell and fractured their hip and had to undergo a surgical repair. They went to a local rehab like Burke, but now returning home, they still need monitoring due to comorbidities that they have. And they still require physical and occupational therapy to ensure they're safe moving about their home and able to perform activities of daily living, like dressing, showering, and making a meal. But you don't have to be a patient that was in the hospital or a rehab center to receive home care. A patient may be living at home with a chronic illness, such as heart failure or diabetes. The patient might have had an exacerbation, and the doctor is now trying a new treatment to manage it. He may refer the patient for skilled nursing to monitor the patient's heart rate, blood pressure, and breathing, and ensure there's no side effects from the medication and that it is working. Another example is a patient may have a disease such as multiple sclerosis or Parkinson's, and it's advancing, and the patient is having a harder time managing at home. This is where the skilled physical and occupational therapy come in. The physical therapist can work to improve the individual's walking and balance so they can safely move throughout their home. The occupational therapist can instruct the patient on assistive devices like a reacher to make daily tasks easier and safer. She can also instruct them in energy conservation techniques to make daily tasks smoother. Our agency provides skilled nursing services. The nurse will assess your health status and monitor and treat pain and symptoms. They will educate you on your medications and how to use them. They will provide wound care. They'll provide post-surgical care. They monitor the surgical incision for any signs and symptoms of infection. They'll help you manage the pain, and they'll manage your vital signs. Skilled nursing can also provide chronic disease management. We also partner with IV companies. If someone needs IV antibiotics, we will help monitor the PICC line and perform PICC flushes. And the nurse also coordinates the care across all the disciplines. So when she opens the case, if she sees a patient's weak or requires a therapy or a social worker, she will request that from the physician, the orders from the physician, and ensure that all these services are in place. We provide physical therapy, and the physical therapist would come out and perform gait and transfer training. They would provide range of motion and strengthening to the upper and lower body, and they would work on the patient's balance. The occupational therapist would come out and look at your upper body and your upper extremity range of motion and strength, as well as your coordination. They're going to look at your activities of daily living and try to instruct you in ways to make it easier for dressing, bathing, grooming, and household techniques such as meal preparation, laundry, those types of areas. They can recommend adaptive equipment, and they can do cognitive and visual training. We also have a medical social worker, and she can come out and assist you with long-term planning. Sometimes she can refer you to people like community home health for aides. She can provide you with information on assisted living facilities and how to complete a Medicaid application. She can also give you community resources, such as what programs the Office of Aging run, put you in contact with Meals on Wheels, and other things available within the county. And she can also provide supportive counseling, because we all know that dealing with the illness can be very stressful, not only to the patient, but to their family and caregivers. And she's able to provide counseling for everyone. And then we have home health aid services. With a certified home health agency, because the services are intermittent, the home health aide goes 2 to 3 times a week for about 2 hours. And they provide personal care, such as bathing and dressing assistance, light meal prep, and just tidying up the patient's personal area, like changing their sheets. They don't do any activities like dusting, vacuuming, or shopping. That would be more Menachem's agency. Benefits of home care? Probably the first and one of the most important is that it decreases hospital readmissions and the use of the emergency room. Our patients can call us 24 hours a day, and we can address their concerns and send a nurse if need be to help the patient instead of going to the emergency room. Home care decreases your calls to the physician's office. We can communicate with your doctor for you. When we come out and assess you initially, and then on our revisits, we can see what's happening, what your vital signs are like, how you're reacting to medications, any changes, any concerns, and then we can speak with the doctor and relay all that information and help him manage your treatment. There's faster recuperation and recovery from illness or injury. Patients tend to show faster recovery rates, as evidenced by a 20% lower hospital readmission rate for those receiving home care compared to traditional hospital care. The familiar surroundings of home contributes to better patient comfort and emotional well-being. Studies indicate that home care patients experience a 25% improvement in anxiety and depression just because they feel comfortable at home. Patients developed improved independence in their level of function. They can take better care of themselves and complete tasks such as dressing and bathing and perform light housekeeping tasks. And symptoms are better managed as there's a communication between the patient, the home care staff, and the doctor. How does home care work? Well, as I mentioned before, we can receive a referral from various referral sources: the doctor, a hospital, subacute rehab, or a nursing home. Then, when our intake department receives the referral, they confirm with the doctor in the community that they'll sign the orders and will assist us if the patient has any needs or issues. Once we have that confirmed, then the clinicians go out and perform their assessments. They develop a plan of care and a frequency based on that assessment, and then they call and confirm it with the physician. Then the clinicians carry out that plan, and they will notify the doctor if there's a change in the patient's condition. For example, they might arrive at the home and the patient's blood sugars are very high. They can call the physician, and the physician can make a recommendation whether maybe that patient needs to take another dose of insulin, or if it's a heart failure patient, if their weight is going up and they're starting to retain water, the physician might recommend that they take extra Lasix. And then that way that would prevent the patient from having to go to the emergency room. The plan of care is valid for 60 days. And if need be, the patient is not better after 60 days, we can reassess them and recertify them for another 60 days with agreement from the physician. Insurances we accept. This is a selection of what we take. We take Medicare, Medicare Advantage plans, Medicaid, Medicaid managed care plans, various commercial insurances like Aetna, Anthem Blue Cross and Blue Shield, Humana, Oxford, United Healthcare, Local 1199. We accept workman's comp and no-fault insurances. When we receive a referral, we have an insurance liaison, and she runs the insurance and makes sure that we are on par. If we don't take the insurance, then we let you know so you can make other arrangements. And if there's a copay, we will inform you before coming onto service so you can make a sound financial decision for yourself. How is a referral made? There's some basic criteria. We only service Rockland County, so the patient must be within Rockland County. Now, a patient could be residing temporarily with a son or a daughter or a friend here in the county, and we can still service them here, even though their address may be in the city or Westchester. But if they're in Rockland County staying in a residence, we can see them there. The patient must be homebound. You must take a taxing effort to leave your home. This is a CMS requirement. You are able to go out for medical appointments, religious services, and hair appointments. But if you're shopping or going out to lunch on a regular basis, then you truly aren't homebound and you can go for outpatient services. You must have seen a doctor within the past 3 months. This also is a CMS regulation. If you haven't seen a physician, We work with you to try to get an appointment, and as soon as the doctor sees you, we will then begin home care services. And as I mentioned before, you must have a diagnosis and a skilled need to be on home care. When we receive the referral, someone from our intake department will contact you and verify your demographic information, confirm your health insurance, your address, and emergency contact information. We'll reach out to your physician and get a history and physical, and we'll try to get a recent medication list and any orders that the doctor may want. And then once that's all put together, we'll be able to begin the home care services. And referrals can be made by having your physician call or fax our office. As the administrator, I know how excellent my staff is, and I'm extremely proud of them. But it makes me even more so when I look at the CMS star ratings. Our agency, in comparison to our local competitors, has received a 4-star quality rating and a 5-star patient satisfaction rating. So that's really quite impressive because that comes from our patients. And we've also received the SHP Best Home Health Patient Satisfaction Award for 2 years in a row. We hope to make that 3 years in June when the winners are announced. I know there are many agencies out there, and we appreciate you choosing Montefiore Nyack Home Care for any of your home care needs. Now I'll turn it over to my counterpart, Menachem, to discuss what services are available after our home care services end, such as private duty nursing and long-term home care.
That was awesome. Thank you so much. So informative.
Yes,
Okay,
and
let me share this.
one question, Menachem, while you upload your presentation, and thank you, Colleen, for that. That was very comprehensive. Can the home health aide administer an enema to a patient? And if not, how can we get a nurse to do it on a weekly basis? Do we have to pay privately for this service for patients that are on Medicaid?
Yes, so that would be more of a private care or long-term care scenario that Menachem's going to speak of now. That would not really be covered under a certified home health agency because it wouldn't typically be considered a regular skilled need to go out and do that each week.
Mm-hmm. Okay. So let's hear from Menachem and see if we can.
All right, you just let me know if you can see it.
We're seeing it, yes.
Perfect. All right, let me do this. Here we go. Bear with me. All right. Hey everyone, Menachem Colt, Director of Sales and Client Relations from Community Home Care. We are a fully licensed home care agency that provides caregivers to those in need. In addition to that, we also provide CDPAP services. So if a family member, a neighbor, a friend wants to be the caregiver, we can provide services, no problem. That is a Medicaid-funded program called CDPAP. So if you are interested in that, but you don't have Medicaid, we help with that as well. Just bear with me. For some reason, it's not allowing me to move to the next page. Bear with me. Okay. Restart. Here we go. All right. So who is Community Home Care? Community Home Care is a fully licensed home care agency that provides caregivers to those in need. We are now also providing LPNs and RNs, and we'll tap into that and what the difference is. But often people are not interested in having a stranger in their home. They're interested in having someone they know, a family member, a neighbor, a friend. So what we do is we actually can pay them to provide those services. Now that program is called CDPAP. It is Medicaid funded, so you have to have Medicaid for that. So we will help you get approved for Medicaid. We'll help you through the process, complete the application, and even cover that cost. That being said, some people, it's not always the option. You need a personal care assistant, you need a nurse, an LPN, so we will provide that for you. Our goal is always to get it covered by Medicaid because it is pretty pricey. But if someone does have Medicaid, we'll do that. If they don't have that, then we'll set up private pay. If you're interested in hearing those numbers, just reach out to me. We'll go through them and we'll make sure it's a good fit for you. If you're worried about having to sign up for too much, more hours than what you really need, we have a very low minimum. So reach out, we'll talk about it. So moving on, our mission at Community is at Community Home Healthcare, we provide compassionate, high quality home care and private duty nursing. We carefully match clients with the caregivers to ensure trust and satisfaction. Our dedicated team is committed to enhancing a quality of life with dignity, independent, and expert care. So the services that we provide, like I was saying, Medicaid is really the start because private pay is an option for some people, but it's pretty pricey. So we normally start with Medicaid, finding out if you have it. If you don't, helping you get on it. That'll be, looking at the assets, the savings. If we have to protect them, we'll show you how to protect them because remember, everyone is eligible for Medicaid. It doesn't matter how much money you have, how much assets, savings, we can get you on Medicaid, and we'll talk about that later in the presentation. Another thing that we mentioned we do now is private duty nursing. That's huge. We'll talk about that later in the presentation as well. But home care, private pay, CDPAP, that's what we do and specialize in. So let's start off with what is the difference between traditional home care and private duty nursing? So traditional home care is just as it sounds. You need help at home. We will send you a fully licensed home care caregiver that is fully certified and background checked. Now, sometimes that won't work because we have a medical need. That could be a trach, a feeding tube, something that a regular HHA or PCA, which is a type of certification that a caregiver has, is not allowed to do. So that's when we will help enroll you with private duty nursing. And that is home care with a nurse or LPN that's full-time. So different from a visiting nurse. So how do I apply for traditional home care? So we're going to start with traditional home care. We started with CHA services. We're going to then go up to traditional home care and then end with private duty nursing, kind of go up the levels. So step one, as always, whether it's private duty nursing or traditional home care, is applying for Medicaid if we don't already have it. Now, some people do have the luxury of setting up private pay services in the meantime, but some people don't, and that's when we get on it right away. A benefit to working with us as opposed to an attorney or maybe even a nonprofit organization is one, towards comparing to the nonprofit, we cover the cost. And then another thing is we get it done very quick. So with the people we work with, of course, we have to compensate them. And we set it up that we only do so once we get the Medicaid number. So naturally, our system is created to just work as fast as possible. That could be providing you checklists, completing the actual application for you and just having you sign the bottom. So we really do as much as we can to just get the job done for you. We understand that you need the services ASAP, as soon as possible. So the next step 2 is scheduling the assessments. So the best way I describe it to my people is we want home care, but how much home care? If it was up to everyone to decide how much home care they choose, the government would go broke. Everyone would go 24/7, 168 hours a week, and there's no way they could afford that. So they created a system where a patient gets evaluated 3 times. And then based on the results, they will decide on how many hours you are eligible for, and if you are even eligible for the home care. Some people, they might say don't need it. Some people, they might say are already past the point. They're not stable enough to receive the home care, and they need to go into a facility or a memory care unit, wherever it may be. So that first step to scheduling the assessments is we call together the NYIA assessor program, and we ask to schedule the first 2 assessments. Now, these assessments can be done virtually or in person. Something strong to note is virtually, yes, you will most probably be able to get them scheduled sooner, and they are a shorter assessment, but in person is a lot more personal. They come over, they have to walk up the steps, they see around the room, you're more likely to get what you need. So based on your flexibility, your ability, we'll make that decision and help accommodate that. So that being said, as the agency, I'm allowed to be on the line to help you get them scheduled. I'm not allowed to be at the actual assessment because that is a conflict of interest. So we will help you with the entire thing, setting it up. We will help you answering any questions, preparing for it. Unfortunately, I cannot be there for assessment, but I've never had any issues with that. They call me as soon as it's done. We go over it. We make sure everyone is confident, comfortable, and then we, after completing the second one, we'll move on to the third, which we'll get into. So the first one is on average about 2.5 hours. Sometimes it's shorter. That is done by a nurse. That is most often just evaluating you cognitively. Then you have the second assessment, which has to be done at least 24 hours later. Most often it'll just be the next day. That one's a lot shorter, about 30 minutes to an hour. It's done by a clinician. So it could be a PA, a doctor, and they're assessing your physical state, if you are capable. It's a lot shorter. They have already a bunch of the results from the previous day. So, it's a little easier for you. So that being said, now that we've completed the first two assessments, we are ready to move on to the third assessment. Now, you won't get the results from the first two. It takes right away. It takes about 7 to 14 days. That being said, you do want to let the agency know that you completed them as soon as you complete the second one, because we can sometimes pull the results sooner. And then sometimes the Medicaid plan, the MLTC, can pull the results as well. So instead of having to wait the 2 weeks and then applying, we can actually just make the referral right away and expedite the process a bit. So step 3 would be scheduling that third evaluation. So once we did the second one, you let us know. We can give you the option of calling the Medicaid plan yourself. We can make the referral for you because we have a representative designated to our agency just to handle our referrals. So whichever way you feel comfortable moving forward, we can help with that. So what we'll do is we'll make that referral. They'll get in contact with the consumer or their power of attorney, healthcare proxy, and they will schedule the third evaluation. That, again, can be done virtually or in person. And once that is completed, we are ready to set up home care services. Now, sometimes you'll get it right away. Sometimes it'll take a bit of time to get the results. It's a case-to-case basis. But once you get those results, you are ready to move forward. You got the number of hours. You can now proceed with the agency you have chosen. Or if you haven't chosen one yet, you can then go out and find one or get one recommended by the MLTC, the Medicaid plan. Now, something I always point out, there is a strong benefit to working with an agency from the beginning. They are your consultant. They want you to start services so they can provide the services. So naturally, they're going to guide you right, make sure you don't take any unnecessary steps, burn any time, any of that. I always say you can make more money, you can make more time. So time is very, very, very valuable. So once we made the referral, the assessment is done, we get the results, we're ready to start the services. Something to note is you have to accept the number of hours offered by the Medicaid plan before the 20th of that month to start the following month. If you enroll after the 20th, you will have to start the following month. For example, if you accepted the hours March 21, you will not be starting April. You'll be starting May. However, depending on your geographic location, there is a loophole we can utilize and get it started by working sooner by working with the DSS. So if you have any questions, you have a situation like that, please don't hesitate, reach out. We'll help with that. I'll explain the process, whatever it may be. All right. So at this time, we've gone through the assessment process. We qualified for hours and we are ready to receive home care services. So what we'll do is if we are already connected with the agency, we'll just let them know, hey, I completed the third evaluation. Let's get it started. Let's get me a start of care date, an SOC. That's when you start the services. If you're not already connected with the agency, you'll connect with one, you'll be referred to one, and you'll let them know. They'll find out how many hours, they'll confirm that they have the staffing, and then they will have you reach out to the insurance plan to request the authorization. There are certain things we are allowed to do. There are certain things we're not allowed to do. One thing we're not allowed to do is request the authorization for you, because we could be requesting them for a bunch of patients that never even spoke to us. So they just want to make sure everything is ethical, everything is done right. Okay. So, and then staying on the traditional home care. So I know there's been a lot going on with CDPAP and the PPL, agencies closing down, certain agencies staying open. So there were 35 that were approved to stay open. And we are very excited to announce that we were one of the 35. So if anyone has any questions about CDPAP, has to find an agency that they know they can get in touch with if something happens, feel free to reach out. I'll be more than happy to help you with that as well. And I'm sure we have questions on that. We're going to do a Q&A at the end. So please jot down your questions. We'd love to take it towards that. So that being said, that's the traditional home care. Now let's tap into the private duty nursing. Now, just a reminder what private duty nursing is. It's home care, sometimes full-time home care, but it's a skilled home care, meaning there's a skilled need that HHA PCA cannot do. It has to be an LPN or an RN. That could be because there's a feeding tube. That could be because there's a trach, just something that they're not allowed to do, they're not allowed to mess with. So now we have to provide an LPN RN. And who do we provide? Is an LPN or RN? We'll talk about that. So step one, just as we mentioned with the traditional home care, it is getting that Medicaid set up, because to do it private pay, especially private duty nursing, is very, very expensive, very pricey. So again, we'll help with the Medicaid application, we'll help with the guidance, we'll help with the covering the cost. We will get it done as fast as it can be done. So I say from the day that you submit the last document, you can count 30 to 45 days before you have Medicaid. That's how long it takes for the state to process it. That being said, I just had a Good Sam referral get it in a week and a half. So it's not for sure that it's going to take that long. It could be done quicker. But what could really make it take a long time is if we hand you that checklist and you're kind of taking your time gathering the documents. That is really what determines the time frame and how much longer it's going to take. Because we do what we got to do, and we're always looking to get you on Medicaid so we can provide the services. So step two, it is a little different. So the agency helps the patient gather the necessary documents. So that can be a letter of medical necessity or MD order stating the hours approved. What it also states is it going to be an LPN or an RN? So it's really up to the doctor, and they are writing the prescription. So they're going to state, do they need an LPN or RN based on the needs? What are the tasks? How many hours? So they are going to include it. And that's why when I work with my social workers and they say, can you send me a template of a letter of medical necessity? I say, not really. I could, but please don't use it as a template, because every patient is very, very different. Whether it's the care they need, the situation, the schedule, it's just always a case-to-case basis. So that has to be taken into consideration. If you're helping someone or you're working on creating a letter of medical necessity, we could provide you a template, but it's not recommended because it is a case-to-case basis. And that is a strong factor in whether you get the services or not. That is the letter of medical necessity. Just like a college student transferring colleges, they go to their professor to get a letter of recommendation, so the next college accepts them, is similar to this. That letter of medical necessity is them vouching that they can that they do in fact need services. So next we have the home safety evaluation. So again, it's a little different than traditional home care. We have to come down and evaluate the home and make sure it is safe for the patient to go home and receive the private duty nursing. Now that can be done by us, the agency, or it can also be done if the patient is on a vent or some type of equipment. It can also be done by that company providing the equipment. So you do have a bit of flexibility to that. Now, another thing that is required is a backup statement from the parents or family. And the reason why I say parents is it's very common for pediatrics to utilize private duty nursing. So let's start with the employee letterhead. So an employee letterhead is basically stating, well, I guess the best way to explain it is the state doesn't want to spend money they don't have to. So if the parent is home and is not working, they want to know so they can not approve hours for that time. So the employee letterhead will basically write out the work schedule. So Medicaid knows when you're at work, when you're not at work, and when they need to provide the services. So going back to the backup statement. So for them to provide these services with traditional home care, the agency is expected to provide the caregivers. There's so many available. There's no reason that someone is not there. With private duty nursing, it's a little more hectic to get an LPN RN. It's also a little more serious. You can't have someone sitting there without the help. There is a medical need. So they need a letter stating the family or parents is in fact trained on whatever the situation is. So God forbid the nurse or LPN shows up late or does not show, we want to know that we're not rushing the patient to the emergency room. We have a backup plan. The family could, fill the void until someone gets over there. That being said, we're amazing at what we do. That rarely happens. It's just part of the process. So step 3, once we gathered all the documents, everything together, we will send it over to the Medicaid plan or the DSS, whatever we're applying for, and wait for the authorization. So something that people can do is you can either get it through a Medicaid plan or the DSS, Department of Social Services. That is a similar process. So whatever it is, we gather everything we've gathered, we submit it to the Medicaid plan or the DSS, and we wait for the authorization. Now, once the authorization is received, once services are approved, with traditional home care, it's a little different. We have some really, really good coordinators that hear out the family, understand the needs. We have a nurse that goes down there, creates a plan of care, and we make the best match with the patient and the caregiver. With private duty nursing, it's different. It's a very intense situation. You got to know that everyone is on the same page. So what we actually do is we schedule a interview. So believe it or not, the family gets to interview the potential RN or LPN. If they're happy, amazing, let's get services started. If they're not happy, we say no problem, bringing in the next. So with PDN, with private duty nursing, you do have the flexibility of choosing your own RN LPN. And I know that's huge because I get that question all the time. Everyone always wants to have a say in who's showing up. 1, no one wants a stranger in their home. 2, you want to know they're quality people. Unfortunately, there's a lot of bad stories out there when it comes to home care. So now that we've spoke about the resources that we could apply for, the coverage that we could get, how do we get it covered? And that's almost always by Medicaid. So let's talk about that. So briefly, let's talk about the Medicaid limits. So when you apply for Medicaid, they look at 2 categories, assets and savings and monthly income. And that is because they're both sheltered differently. Now, don't forget, if you're over the limit, you are eligible for Medicaid, 100%. We just have to do a bit of sheltering, and it's easy, and it's cheap compared to what you're going to save. So basically, just to keep things simple, because the single is an even number, we're going to use a single person as an example. So a single person is making $2,300 a month. The limit is 18. I want to get onto Medicaid so I can receive these resources and not pay out of pocket. So what we do is we set up a pooled trust, POOLED. And how does that work? So we basically take $500 and move it into the pooled trust because remember, 18 is the limit. We're only at 23. We don't have to shelter the whole 23, just whatever's over the limit. So we will take 500, move it into the pooled trust, and that will allow you to get on Medicaid and not forfeit those funds. Now you're wondering, what's the catch? What am I paying the company? So they will take 10% of whatever you move over. So that's only $50 out of the 500, not 10% of the 2,300. And you're saying, but then I have to pay the 10%. Well, just a reminder, home care, not even private duty nursing, home care costs a little more than, or I should say sometimes a lot more than $3,000 a week. So that trade-off, 100% worth it. Now, people are always, well, what is the pool trust? You want to learn more about it. So one, reach out to me. Would love to connect you with our pool trust expert and tell you more about it. But just briefly, it's basically a trust managed by a nonprofit that allows you to become eligible for Medicaid. So that whether it's because the rules it puts on how you spend the money, this, that, reach out, we'll get more into it. It can get complex, though we know how to make it simple. So just because I mentioned it, we spoke about what you're allowed to spend your money on. So you are allowed to spend your money anywhere. It's really what it's on. So the way it works is you moved 500 in, you're now left with 450. How do I spend it? You have two options. One, we give you a debit card and we say, spend your money, enjoy. Two, you give us bills and we will spend it. We will pay it. Now you're wondering, where can I spend the debit card? You're not limited to where you can spend it. You're limited to what you can spend it on. So when you buy something, there's a barcode. And when you scan it, it's categorized. Dry foods, fresh produce. So something you're not allowed to spend the money on is tobacco, firearms, gambling. You're also not allowed to pull cash. So you are able to spend it at a liquor store, but only if you're buying a soft drink, a soda, a water. If you're trying to buy beer, it's not going to work. So if you call me, you're at Walmart, my card is not working, I'm going to say, what's in your cards? Do you have gift cards? That's like pulling cash. Do you have, scratch offs? What do you have in there? Something is not allowed to be there. So you still stay very flexible in regards to how you can spend it, where you can spend it. It's just, you have to be on top of that a little bit, keep in mind. So the next category is savings and assets. So one thing I just want to debunk, if you own a home and it is worth less than $1 million and 71,000, it is not taken into the equation when applying for Medicaid. If you own a second home, a third home, or you're not living in it, you're renting it, then it becomes an asset. They say if you're living in it and it's worth under a certain number, that is not an asset, that is your residence. So now that that's out of the way, let's say you're over the limit of 32,396 or 43,781. So what we have to do is set up an irrevocable trust. Now, again, you can just shelter what's over the limit or everything together. But what that does is it allows you to apply for Medicaid. Now, that is a little bit more pricey to set up. You do have to utilize an elder attorney. But I remind you, you spend $2,500 to set it up if you get a normal price. Remember, you're going to be spending $3,000 a week. So the one-time 25 is nothing compared to that 3,000 that you might have to start spending, every week. So that being said, that's the basics of Medicaid. We didn't dive too much into it. I do know a bunch about it, do training. So if you have any questions or concerns, please reach out. Would love to answer all of them, connect you with the right attorney, whoever it may be. So here in front of you, you have two of our flyers. You have on the left for the traditional home care. You have on the right for private duty nursing. I didn't mention long-term care policies. They're not so common these days, but if someone does have a long-term care policy, we work with those as well. Reach out if you have to put in a claim, whatever it may be with the long-term care policy. We have experience with the entire process. So reach out. We would love to help you with that and provide the services. Private pay, long-term care policy, Medicaid, private duty nursing, CDPAP, we do it all. If it's something that is not anything that I mentioned, but you are still looking for help, something geriatric related, you can still feel free to reach out. I'm the founder of a nonprofit called the Kosher Senior Community Page. It's like an office for the aging, but for global. So it doesn't matter where you are, you need help, let's connect. And that's my pitch.
Well, thank you. Thank you so much to both of you. And now we're going to open for questions. I do have one to start. I understand that as we grow older, we, of course, compromise our health and we fall and all of that. But okay, I know you mentioned that there might be some children that might need help, but is there like an age requirement? No.
No, there isn't. So especially if you're private paying, super flexible. It doesn't matter how many days you need, how many hours you need, the age, you pay the bill, we'll send someone good. In regards to the Medicaid, it's a little different because remember, we're not working with marketplace Medicaid or nursing Medicaid. We're working with community Medicaid. And community Medicaid, you need a medical disability or to be over 65 to qualify. So that is something to know. So if you're trying to get it through Medicaid, you do have to be eligible for it, which we'll be more than happy to get on the line, go through it all, and show you how you can be eligible.
And for our services for the Certified Home Care Agency, we only take care of adults, so 18 and older.
Okay. They're asking me to ask you the same question, Menachem, about the enema to the patient. If somebody needs an enema on a weekly basis, do they have to pay privately for the service?
So that's a good question. I would want to look more into it, see if there's anything else that we could put on the list. That might, I would have to look into it. That might be similar more to like skilled nursing, where just a nurse does a short visit that day. Right. Which we don't do, by the way.
Okay.
So that is more Montefiore Nyack,
Okay.
I believe. Correct me if I'm wrong.
So, you know, the enema in and of itself can or cannot be skilled. So it all depends. You know, if there's caregivers in the home that can provide that, then they would do that. We're supposed to be certified home health agency as a short-term service. So, you know, you're only on for so many weeks. So if you really need like a weekly ongoing issue like that, you know, either we would have to train a family member or caregiver to do that. We could not provide that, as it doesn't meet the criteria of CMS for a
Right.
certified home health agency.
So in that situation, I would say, let's connect, reach out, let's dig in, see if there's anything else we could put on the list of tasks and, you know, make it doable. And also, of course, you know, like Colleen said, evaluate the actual enema situation. Like maybe it is an extreme case.
Yeah. Is it possible to have an aide and private duty nursing at the same time?
I believe so. I believe it, of course, you know, depending on the need, you know, the time of day. I believe I've seen it before. Yes. And then I always say, like, I have people apply for both literally at the same time. What if one comes through and one doesn't?
So in certified home health agency, if you had a MLTC program and you had an aide through that, you would still qualify for the aid services through us on an intermittent basis to kind of relieve that aid while you're on service with us. So, you know, we could come out 2 days a week and give you a shower and get you lunch while that aide maybe took a break or went and did your shopping or did your laundry or something like that. So we can overlap in that respect for home care.
Another question is, do you serve counties other than Rockland?
Our agency at the moment only serves Rockland County.
And my agency, so we service just about all of New York, except the 5 boroughs. However, I have people all over. I've placed people as far as California. So it doesn't matter where you are. If you need help, reach out, let's connect, and I'll make it happen for you.
Let me see, what else? If there is, let me see. No, I think all the other questions are just related to what we just said. And then here we say, do they cover home care through Medicare?
The certified home care agency is covered through Medicare, yes.
So Colleen's agency is, our agency is not. So we only work with Medicaid, long-term care policies, and private pay. But we do contract with agency like Colleen, where if someone does need the home care, but they don't have their own caregivers, we will actually, third party, will provide the caregiver.
And if we contact you to get some advice, do you charge for that? We're looking into an elder care manager to get started, but maybe not necessary, so they don't know where to start.
No, so everything is free. I'm available 24, I say 24/6, 7 is for emergencies. So I would say reach out evenings, weekends, it doesn't matter. I'm actually reachable more than just during business hours. So let's connect, reach out, and more than happy to help. I'll put my number here in the chat.
Okay. How do we proceed with people as far as sign in, etc.? Where do we get a list of agencies approved to be PPL? I'm not sure what PPL means.
Sure. So the PPL is the new agency that's taking over CDPAP. So the way it used to work is you had a bunch of agencies, almost 700, getting managed by the state. And they were like, this is very expensive. It's a little cheaper if we manage one agency who manages, instead of 600, 700, 35 agencies. Now, it did originally start with a higher number, and it just kept getting lower and lower. So at this time, there's only 35 agencies that are subcontracted under the PPL. And the PPL is who's managing it all. So if you go to the PPL's website, you should see an agency that is in network. Something to note, I just got a call from someone yesterday looking for help through the PPL. And they were like, well, if you ask me, like, oh, you probably brought them to your agency. I actually didn't. Why? Because I saw right away that they were going to need PCA services and even NHTD services within the next few months. So I was like, what are we going to do? Enroll you here and then transfer you there? So something to note is try and utilize an agency that is certified to provide traditional home care in your area, because the benefit is you're going to be working with the same people if you change over to traditional home care from CDPAP. You're not meeting a whole new team. You're not starting from scratch in regards to relationships, and you could even do the PPL while working on applying for NHTD. And I know some people probably know about NHTD. Some people probably, are only just starting to hear about it. You can feel free to reach out to me. I'm more than happy to answer any questions about that, or, help you get approved for the waiver program. But we are also having another event that will focus on Alzheimer's, dementia, and NHTD. And I'll share that with Sandra to share with everyone. And, more than welcome to join for that as well. So my recommendation is PPL website, utilize an agency that can also do traditional home care in your area as well.
Another question, for extreme Medicare cases, Medicare allows 28 hours HHA services, but all agencies seem to not allow it. Why?
What was the question?
For extreme Medicare cases.
Oh, Medicare.
Medicare.
That's a question I get all the
hours.
time. Colleen could answer that one. So everyone always calls me. Google is stating I'm approved for 35 hours a week, but the agency won't give it.
So really, it has to come down to staffing very often. Home health aide positions are very hard to fill, unfortunately. And, we want to ensure that all of our patients receive services. And the, although it says that, I mean, the regulation is it's intermittent and short term. So, that means it's spread out. It's not like you get just someone sitting there for X amount of hours in a day in your home. That's not what certified home care is developed for. But that's where these other long-term programs like the MLTCs and the private duty, those types of things are more geared towards that.
Right. And we're coming towards the end. We only have 3 minutes, but I do have a question that I would like to make. Once you get your help at home, LPN, RN, any professional that comes, are there any reasons why they might or need to be removed from the home and helping a patient? I know we always put the patients first, but sometimes we also need to think about, our nurses and how to protect them. So what will be some of the cases where we need to remove some of the nurses
Oh yeah.
or aides from homes?
So, I mean, for us, sometimes, is personality. Sometimes, the cases are very intense. So someone might have severe wounds, or multiple drains that need to be, taken care of. And it's very physical for the nurse to perform, day in and day out. So, we might need to rotate them out and put somebody else in there to kind of give them a break. Our nurses are very compassionate and empathetic. And some of these cases, people are very ill. We see patients with chronic illnesses that they're most likely terminal. We have patients with cancers, and it's very emotional. You get attached. Sometimes we need to give the nurse kind of an emotional break, and we'll ask a different nurse to go in and cover for them. And sometimes it's just plain old personalities. It's a little oil and water, and we know that maybe it's not the best for the nurse or for the patient, and then we'll switch out the nurse or the PT or the aide, whoever the professional may be.
Thank you. Menachem, do you have anything to add? We have like 60 seconds.
Yeah, so 100%. It literally happened the other week. I got a referral, and I heard that just no agency was able to retain it because it was just a very combative dementia patient. And I basically said, like, what my agency started setting up services. I said, no, this is pointless. We're only going to last a few days. I put them right into a memory care unit. So sometimes it's just you get to the point where it's the level of care or the patient themselves are just combative, not willing to take the help. And then we'll put you in a facility. If you become open to receiving the care, we're welcome to revisit it. If the medications stabilize you, like whatever it may be, we're not shutting the door on you, but sometimes it's not safe. I've had families where a patient, goes at, a grandchild or something. So sometimes we just have to take the patient out.
Yeah, that's sad. Well, thank you so much. We ran out of time, but thank you, Colleen. Thank you, Menachem, for being here and, for all this information that you shared today and to our attendees for your attendance, obviously, and for all the questions. And you got the phone numbers in the chat. If you have any further questions, I'm sure Colleen and Menachem will be happy to answer. And next week, join us to learn more about asthma and how, if we are the patient or the caregiver, we have resources out there that can help us better manage the asthma. So thank you so much, and I'll see you next week.
Thank you so
Thank
much.
you. Have
Thank
a
you for
good day,
coordinating.
everyone.
Bye-bye.
Be well.